Hello, good afternoon, everybody. I can see some people are just logging in now. I think we're just a couple of minutes past 1, so I will get us started. Good afternoon, welcome to today's lunchtime webinar. I hope you have a delicious sandwich or samosa, or maybe a cup of tea at least at your side to tuck into, because today we're going to be hearing from 2 top campaigning organisations and 2 top campaigners. My name is Tamora Langley. I work at the Parent Infant Foundation and also coordinate the First 1001 Days movement. So the speakers we're hearing from today are from 2 charities that are very closely involved in the movement. And the First 1001 Days movement, as you may know, brings together charities, but also professionals who all share one very important aim. And that aim is for every baby to be able to enjoy a loving, nurturing relationship, because we know that's the foundation for healthy development. But because we know also that sadly not every baby has that, we're really passionate about getting help and support to those who need it. So today's webinar is on a sensitive but really important subject, which is how we can help babies and also young children who experience neglect, many of whom are vulnerable and sadly quite invisible to wider society. So first, we're going to hear from Jack O'Neill, who is Senior Policy and Public Affairs Officer at the NSPCC, which is the UK's leading children's charity preventing abuse and helping those affected to recover. And second, we'll be hearing from Georgina Mayes, who is the Policy and Quality Lead at the Institute of Health Visiting. And that's an independent charity, professional body and centre of excellence established to strengthen the quality and consistency of health visiting practice. So Jack and Georgina have each got a presentation lasting around 15 minutes, maybe 20 minutes for the second one. But as they're talking, please, if you have questions, do type them into the Q&A box, because at the end, we've allowed 15 minutes or so for questions, and we're going to end at 2 o'clock. So can I welcome, please, first, Jack.
There we go. Hopefully everyone can see those now. Yeah, thank you very much for the introduction and for the First 1001 Days movement for inviting Georgina and I to speak on this very important issue. And most importantly, thank you to all of you for tuning in during your lunch break to listen to us. My name is Jack.
Sorry, Jack. I'm afraid I think we've got a problem with the sound, so let's just make sure that people can hear you okay. Yeah, we were okay in the test run through, so let's just see if you can say something else and we'll see if it's what's happening.
So the importance of the early years really cannot be understated. It is a time that lays the foundation for health and well-being, with factors such as their environment and risk of exposure to harm, all impacting a child's safety and development. In 2020, serious incidents to a child. Of these incidents, 39% sorry.
I'm sorry, the sound is impossible, Jack, for me, and I can see a couple of participants having a problem. And my colleague Ben in the background is looking to try to see if there's anything that can be done about that, which is a little bit baffling. I'm wondering if we go through, there's several people can't hear, I'm afraid. I don't know if it's because we're all in different locations. I would just quite like to see if Georgina can come on screen and say something, and maybe we'll go to her presentation first.
Hi, can you hear me okay?
I can, Georgina, yes.
Okay, that's good. You can hear me.
I'm really sorry. What my suggestion is we flip the order so that we can then come back to Jack in a second.
Definitely. I'm cool with that. If Jack, you're okay to move the slides on to where I start, that's okay.
Thanks very much.
There we go. I think that's the first one. Well, I'm glad everyone can hear me, and everybody that logged on a little bit early probably heard us in our planning too. So it's really good to see so many of you here today. And my name is Georgina Mayes, and I am the Policy and Quality Lead at the Institute for Health Visiting. I'm absolutely delighted to be here presenting alongside Jack, and fingers crossed we can hear Jack very soon. I'm just going to kick off with who are health visitors and what do they do, because I think one of the biggest challenges that we face as a health visiting profession is that people don't understand our role. And we've created a number of resources at the Institute of Health Visiting to help people understand the roles. So to the left of this slide, you can see an infographic there. And to the right of the slide, we've got a couple of films that we've made recently. And there's links to those films that you'll be able to access afterwards, because we'll share the presentation with you. Or I can see people can hear me fine, which is great. And yeah, you'll be able to watch those at your leisure just to kind of get a better understanding of the role. We know that the work done by the Royal Foundation with now the Princess of Wales, they did some research around the importance of the early years. And it's really quite shocking that only 1 in 5 adults understand the importance of the early years. So it makes it even more difficult to understand the role of the health visitor who predominantly work within the early years arena. So effectively, health visitors prevent, identify and treat problems before they reach crisis points. And for those of you that don't know, health visitors are registered nurses or midwives, and they have additional training within public health as well. And they work with all families, so it's a universal reach to all families, right through from pregnancy until the child starts school. And health visitors can provide extra support when families need it the most, and they can build on family strength. They can prevent costly problems or spot, problems early. And they work across a number of pathways. So looking at the infographic on the slide here, you can see all the different pathways that health visitors cover. So not only do they cover physical health for adults, but they also cover physical health problems for children as well. And they work across social needs and safeguarding, mental health, as well as child development. And so you can see that the role of the health visitor includes elements of the Start for Life vision, which I'm sure some of you are familiar with. And they mainly focus on breastfeeding, perinatal infant mental health and parenting. I guess the point I'd like to make today is that we must not forget that the health visitor role extends way beyond that. So it includes the postnatal physical care, oral health, obesity, urgent care attendances, for example, and SEND. And all of these are real pressing priorities now. And we also need to be building a workforce for the future. And we know that we need to strengthen the health visiting role in new priority areas like genomics and preconception care. So Jack, can you do next slide? Thank you very much. So health visitors have a key role in preventing neglect. They're really well placed to undertake safeguarding and child protection work through their leadership and delivery of the Healthy Child programme. And health visitors, when adequately resourced, can build trusting relationships with families and also provide that continuity of health visitor, which is so important. The advice, support, information giving that health visitors routinely provide universally to all families has an impact on reducing the risk to babies and young children. Health visitors' skills in that holistic assessment of the child and family well-being means that they can easily recognise when things are not quite right or when families have additional needs. And this is when timely referrals for early help or a step up to targeted or specialist provision may help a family and actually prevent the situation from deteriorating or resulting in harm to a child. For some families, a referral to children's social care is needed, or in an emergency, even the police. And in these cases, it's really important for the health visitor to be able to clearly articulate why they are concerned, what their input has been, and what their continued input will be. And the notion of working together reflects that real open and honest relationship with the parents, as well as the partnership with other professionals and agencies that are involved in keeping the child safe and well. And you can see the quote at the bottom of the slide here: health visiting is the backbone of the early years and are considered the safety net around all families. And UNICEF recently published a document which you can see in the right-hand corner of the screen there, Early Moments Matter. And this was quoted within this report. And it is absolutely true, health visiting really is that backbone of the early years, and they really do provide that safety net to all families. Jack, can you do next slide, please? Thank you. So even before the pandemic began, we had a growing number of invisible, vulnerable babies and children. And this was recognised as a serious national concern, with 2.3 million children in England growing up with vulnerable circumstances, with more than a third not known to services and less than a fifth receiving support from children's social care. And this slide here just highlights some of the shocking statistics from a recent health visiting survey that the Institute of Health Visiting published earlier this year. And it's the largest UK health visiting survey of its kind, completed by 1,323 practitioners. And what you can see here is that health visitors are really worried about safeguarding. And actually 60% of health visitors have reported further increases in child safeguarding over the last 12 months. And this actually builds on previous reported concerns as well. And health visitors are saying that health visitors are saying that there's soaring needs as well, and there's widening inequalities, and this has got much worse in the last 12 months. And so you can see here, nearly all health visitors, 91%, and this is UK-wide, are reporting an increase in poverty affecting families. 91% of health visitors are also reporting an increase in families needing to use food banks. We've also got soaring needs in terms of perinatal infant mental health and homelessness and asylum seekers, and also increases in domestic abuse as well. And to the right of this slide, you can see the Casting Long Shadows, which was a report that was produced looking at the impact of the pandemic on babies and young children, which actually showed that babies born in the pandemic are falling behind with their social skills and more have experienced abuse and neglect. And actually those that come from the poorest backgrounds are actually affected the most. It's probably important here as well, sorry Jack, just go back. In terms of what health visitors are seeing, it very much is an early warning signal, because what health visitors are seeing now kind of ends up on the government's desk much later as data. So it's really important what health visitors are seeing, that we listen to that, because it kind of presents the most pressing kind of risk to our most vulnerable babies and children in society. Thanks, Jack. Next slide. So looking at safeguarding and the current picture, health visitors are really concerned about invisible vulnerable babies. And I know in Jack's presentation, he's going to be giving you some more kind of national data. But looking at children on child protection plans, there's been a slight increase, 1.8% from 2021. But actually, health visitors are concerned that there's much more child safeguarding out there, and that the national data actually masks some of the problems that they're seeing. And health visitors are really worried that cases aren't actually being detected, because we have less health visitors now than what we've ever had before, which means that health visitors have got less time to spend with families and less time to be able to identify those needs and identify neglect. So this is really worrying for them, thinking that there's more kind of invisible, vulnerable babies and children out there. And what health visitors are also saying as well is that the thresholds for children's social care has actually changed. And now that there's more children living with significant vulnerability, and they're falling below those higher thresholds now. So there's actually sort of more unmet need than ever before. And looking at the graph on the right-hand side of this slide here, you can see this is about referrals to children's social care. And you can see a big dip down there in the school holidays. And this really highlights the importance of schools and also the adults in children's life in terms of being able to identify that child maltreatment or neglect. And you can see when they go back to school, those referrals go up. So this begs the question, what about babies? Who is looking out for them and joining together the pieces of the jigsaw for babies in distress? Because babies aren't going to school every day and being seen by teachers every day. So it's really imperative that we have a robust and well-resourced health visiting universal service that reaches all families as a safety net to identify babies in distress whose parents may not have the agency to advocate on their behalf. And looking at the national review into the tragic death of Star Hobson and also Arthur Labinjo Hughes, it was highlighted within this review that practitioners need to be given the space and time to do the quality work with the child and baby and the family to critically reflect on the baby's experiences, including putting together the pieces of the jigsaw that they hold about them and the network around them. Next slide, please, Jack. So how are we responding? So you may be aware we've got less capacity than ever before within health visiting services to be able to identify need, which really does raise that concern about invisible babies and young children. And OHID actually present quite a worrying picture about children's health reviews. So we know that 1 in 5 children in England are actually missing out on their vital health and developmental reviews. And actually for the 2 and 2.5 year review, that's as many as 1 in 4 children. And shockingly, nearly 500,000 checks were missed during 2021-22. So the national data shows some small increases in the uptake of the universal health visitor reviews in England, but actually this masks significant variation between the highest and lowest performing local authorities. And you can see the chart on the right-hand side of the slide here. So for example, the new birth visit by 14 days in the lowest performing local authority, it's as low as 4.2%. And in the highest performing local authority, as much as 99.1%. A huge variation between local authorities. And this is also showing as well that these mandated contacts are including non-face-to-face methods as well, despite concerns being raised about the safety and effectiveness of these methods. So you can imagine for being able to identify neglect, the importance of these 5 mandated contacts to be able to see the family in their own home face-to-face, and particularly with neglect to be able to understand the child's lived experience, what the house may smell like, what it looks like, who's present in the home. It's very difficult to do that on a virtual platform. Next slide, please, Jack. Thank you. So in terms of capacity to respond to identified needs, so the Institute of Health Visiting survey actually mirrors some of that national data that I just talked about previously. And at the top of this slide, you've got the percentage of health visitors who reported that all or most families received universal health reviews by a qualified health visitor. And so you can see for the antenatal visit, and this is UK-wide, only 13% of families had an antenatal completed by a qualified health visitor. And for the new birth visit, nearly a quarter of those new birth visits weren't completed by a qualified health visitor. And for the 2 and 2.5 year review, it's as low as 12%. And so some of the biggest barriers to making a difference, basically there's not enough health visitors. So 85% of health visitors said there's just not enough of us. And interestingly, even when health visitors have identified concerns and referred on to another service, 86% of health visitors are saying there's not enough capacity in other services to be able to pick up those onward referrals as well. And 64% of health visitors are reporting that they're having to prioritise the most vulnerable and safeguarding, which leaves very little time for that early intervention or prevention work. And only 7% of health visitors actually feel confident that families will be able to access the support that they need when a problem's been identified. Next slide, please, Jack. So this slide just has two quite interesting graphs on here, and it's all to do with the cost of child protection and also a late intervention. So we are actually spending £23 billion a year on late intervention, which is a huge amount of money. And you can see the slide to the right. So this is local authority with children's social care workers. So we actually had an increase in children's social care workers between 2017 and 2021, and just over 4,000 more children's social workers were employed. But we know that funding into children's social care is currently being invested into a model that isn't working, and the level of investment actually isn't enough compared to what is needed. And the independent review of children's social care illustrates the scale of investment into this kind of new model as well. And meanwhile, other areas haven't seen any investment at all, and health visiting is an example of this. So to the left is the current situation with health visiting in England, and you can see a steep decline in health visiting numbers from 2015 to present day. And actually this graph was made in January, and we've just had some recent data in, and since this graph was produced, we've lost another 242 health visitors. The numbers are dramatically falling. We now only have 6,651 health visitors in England, compared to the peak in 2015, where we had about 12,000. So a huge dramatic drop in health visiting numbers. And what does this mean, and why does this matter? It is having a knock-on impact, these health visitor reduction in numbers, on other services and other organisations, and families are really feeling the brunt of this. And previously, at the peak of that graph in 2015, families would have gone to their health visitors for support if their baby was crying or they were unsure, having feeding problems. But now more and more families are turning to A&E for support. We know that immunisation rates are falling, children living with overweight and obesity is rising, inequalities are widening, and there's much later identification of clinical and safeguarding vulnerabilities as well. And there's three key drivers behind the fall in the health visiting numbers. And firstly, that's a cut to the public health grant. So we've had 24%, or in effect 1 billion lower in real terms compared to 2015-16. We've actually had cuts to health visitor training places, and consequently lots of health visitors are now leaving the profession. So really a whole system approach is needed to ensure that all families and children receive the right support at the right time, and investment in the early years is an opportunity to provide preventative and early identification support. Next slide, please, Jack. So there's many policy opportunities with a strengthened health visiting service, and health visitors can offer support with healthier pregnancies, improved birth outcomes, prevention of child health problems. And they very much use a strength-based approach to support families during the transition of parenthood, and can prevent problems such as perinatal and infant mental health, which can have significant societal costs. And looking at the independent review of children's social care, who highlighted that children's social care picks up the needs of families which universal and other services cannot address. Therefore, getting the right support for families through universal services, and wherever possible, addressing issues before they escalate, is critical. And there's also, in terms of the review of the murders of Arthur Levin Joy Hughes and Star Hobson, which I talked about earlier, workforce was never in scope when this was written. However, they did identify the issue of capacity in health visiting services is of national concern and merits further attention. And looking at the Best Start for Life policy, which I'm sure lots of you will be familiar with, and health visitors are actually listed as one of the 6 priority services in the Start for Life vision. And as part of this vision, the health visiting workforce pilots present as a really great opportunity to address some of those workforce issues. But decisions need to be based on evidence, as we're particularly concerned at the Institute of Health Visiting that the scope of the evaluation will be limited to the Start for Life priorities, and not necessarily the breadth of the Healthy Child programme or the health visiting role, which I identified earlier. And this is a really big worry, and we have raised this with OHID, because it has potential to present quite a blinkered view of what is needed to deliver the Healthy Child programme and address all of those determinants of health if this is not addressed. Next slide, please, Jack. So rebuilding in the real and messy world, because out there it is real and it is messy. And there's key ingredients that we need to be able to turn this around for babies, children and families. And based on proportionate universalism, all families need a little bit of support, and some families will hardly need anything. And having a baby is a period of dynamic change for families. So how you are in the antenatal period may be very different to how you are in the postnatal period. For example, your baby may be born premature, may be sick or have a disability. So we need a system that is responsive to meeting those changing needs of families over time. But there'll also be those families who have multiple and complex and coexisting needs, and they often don't know where to start. They feel stigma, they feel shame, they struggle to reach out for help. And what they need is somebody with the skills like a health visitor to get alongside them, to build those relationships and have the time to do that. Because we know that relationships are absolutely key to improving outcomes. And we shouldn't fragment the support that we provide to families facing the most challenging time in their lives. They need somebody to stand through them with that journey, somebody who can work through the details of their life, and where they're getting a certain type of outcomes, imagine a life with a new set of outcomes, and to build their life towards that with a plan, building on their strengths. And this takes great skill to do. It's certainly not a tick box exercise. And it's important that we don't just focus on interventions. We need to prevent problems from happening in the first place. We need structures in place to identify vulnerable children with clinical vulnerabilities, safeguarding vulnerabilities, and also to be able to engage families with the right support. And families often don't recognise that they have a problem, and they're certainly not queuing up with big signs saying that they're vulnerable. And again, it takes a person with great skill like a health visitor to recognise this and engage them. And often the families who need help the most are the ones who disengage. And we have high rates of attrition for these families. And this is where we need services like health visiting to catch them, provide that safety net, and have the skills to work through those barriers with them. Next slide, please, Jack. So at the Institute of Health Visiting, these are some of our key asks to government, and I think this kind of mirrors with Jack's presentation earlier as well. So it's really important that we prioritise the first 1001 days of life, because it really is the smartest of all investments. And we need a shift towards prevention and early intervention to support all people to lead healthy and fulfilling lives. And equity of access is really important so we can reduce that postcode lottery of support. We also need systems thinking, because the benefits of an effective health visiting service accrue to numerous government departments across a person's lifetime. And we need those integrated clinical care pathways, which are significantly front-loaded in investing in prevention and early intervention. And also strengthening the health visiting service, and this requires a clear plan with 3 areas in focus. Firstly is around funding. So all areas need sufficient funding to be able to deliver the Healthy Child programme in its fullest form. Also, in terms of workforce, we need a demand-driven, well-resourced national workforce strategy to increase the numbers of health visitors and address the current and forecasted losses as well. And quality, we really need a plan to reduce that postcode of lottery that families are really feeling the brunt of right now. Because we know when families are supported, babies thrive and all of society benefits. I think that takes me to the end of my presentation. I'm sorry it's the wrong way around. And hopefully Jack may be able to come in and be heard next.
Thank you, Georgina. I'm going to attempt to be heard. I've put some headphones in, so
Yeah.
hopefully people can hear me.
I can hear you.
Okay, Georgina's giving the thumbs up, so we shall try and start again, but I have told Tamora and Ben that if there are any issues, just give a shout and I will find another way to communicate with you all as well. So I'm going to try and share my screen, and yeah, as Georgina said, apologies for this being in the reverse, but hopefully you will all be able to get the same amount of information and hopefully still find it of use as well. So yeah, ignore my first introduction. Georgina,
has introduced the subject, and I'm going to come in behind now as well. So I won't repeat the stuff that I attempted to speak in sort of probably a Dalek-like voice for you all, but I will just give a really quick overview into why we're talking about this issue today. So in 2020 to 2021, there were 536 serious incidents to a child, which was an increase of 19% from the previous year. And of those incidents, 39% were children under the age of 1. ONS data also shows from 2021 that babies under 1 remain at the highest risk of homicide compared to any other age group, and specifically the death rate of babies aged 0 to 27 days is twice the death rate for babies aged 28 to 364 days. So not only are the early years period important, and not only are the first 1001 days critical, but those first 28 days of a baby's life are the most vulnerable period. But also, as Georgina has beautifully illustrated, it is also the most opportune moment and opportune period to embed positive, preventative and loving care as well. As it is during this time that foundations are set, relationships with practitioners and professionals can be built, and any signs of maltreatment or further needs can be identified so that the child and family can receive support as early as possible. Without this opportunity for early identification, problems can worsen over time. We know that children exposed to antenatal depression and childhood maltreatment are at almost 12 times greater risk of developing mental health problems than children not exposed to this. Through investing in early intervention and prevention services, these problems can be tackled so that every child feels supported, every family feels supported, and in turn, every child is given the opportunity to thrive. So within the current context of the cost of living crisis, it is really important to acknowledge the pressures of poverty and the impact that this may have on neglect. First and foremost, I want to stress that parents or carers being from low income households does not equate to poor parenting. While these parents or carers may be aware of their child's needs, financial pressures may mean they are simply unable to meet them. It may also be that the emotional impact of these financial pressures negatively impacts their mental health, which can have knock-on implications for the parent-infant relationship. This is particularly important to consider in the early years when considering ongoing costs. So, for example, even the growth of a baby and infant and the need to change clothes, and how this may exacerbate financial stress for low-income families. So whilst this rise in poverty must be considered when questioning changing levels of neglect, I would also like to draw everyone's attention to the concept of affluent neglect. Affluent neglect can range from emotional neglect to educational neglect, where the parent or carer is not engaged nor providing the time investment into the child's life, or where the child is impacted by being passed around from one paid carer to another without developing sufficient relationships or attachment. So therefore, whilst it's really important to consider poverty and its impact on child neglect, and also the wraparound support that is available for a family, this is happening along a wide spectrum of needs from a family as well. So it's really important that we consider this topic and talk about it in a sensitive way. And equally, I'm aware that whilst Georgina and I are the ones presenting today, there's lots of expertise in the audience as well. So even if it's not a question, even if it is just an observation, whether that be from policy or practice, with regards to how this rise in the cost of living crisis is impacting on this subject, then I'd be really interested to hear all of your thoughts. So this is potentially a bit of repetition now because Georgina did touch on this, but in late October last year, the annual Children in Need Census illustrated the current picture of the prevalence of abuse and neglect experienced by children. So the data provides information on children in need in England, including children on child protection plans, referrals to and assessments by children's social care services. So in the most recent reporting year, there were 404,310 children in need, which is 4.1% increase on the previous year and the highest number since 2018. And then in terms of child protection plans, as Georgina referenced, there was 50,920 children on these plans, which was an increase of 1.8% from 2021. These child protection plans document what sort of risk the child is experiencing, and I'm briefly now going to cover this data set in a bit more detail, including some of the limitations of the data set and also some of the trends that we can identify that help illustrate the changing levels of abuse and neglect and potentially some of the drivers for this as well. Now, as Georgina covered and touched upon slightly in terms of what health visitors are informing, it is important to caveat that this national data set may not be telling us the full story. So there are pressures across the whole of the system that mean that this data may only be showing a partial picture of what babies and young children are experiencing. Firstly, there is that risk that cases are not being detected due to practitioners' reduced contact with families as a result of cuts to services. With a workforce shortage of at least 5,000, the health visiting profession is stretched and under-resourced. Resultantly, approximately 84,000 babies didn't receive their new birth visit within the recommended 14 days. And as Georgina said, by the time you get to the 2 to 2.5 year review, a quarter of children aren't receiving this. This lack of engagement with support services means that there's potentially babies and young children who are distressed or at risk of harm who are invisible and undetected by services. Secondly, intervention has disproportionately shifted to late stage crisis point intervention, consequently leading to higher thresholds for intervention. With Section 17, child in need thresholds set locally, and with participation by the family voluntary, designing and delivering effective services is challenging. With a high degree of variance between local authorities, some areas may have a higher threshold for social worker involvement. Therefore, rather than a declining level of need, some children living with significant vulnerability may fall below these higher thresholds. And as Georgina said, both of these factors are things that are being identified and highlighted on the ground, with a note of caution that we can learn lots from the children in need data, but also that there is probably a lot more going on as well. Saying this then, there is still a lot that we can glean from this data. So in the most recent reporting year, 1,330 unborn children, 4,440 children under 1, and just over 12,000 children aged between 1 and 4 years old were on child protection plans. This is just under 18,000, and that makes up over 35% of the total number. Whilst neglect has increased by 1.3% across all age groups, it is increased by 7.4% for under 1s. And of all cases involving under 1s, neglect was the initial category of abuse in 56% of the cases, which rises to 67% for unborn children as well. Therefore, not only is neglect involved in the majority of cases involving the youngest children, but it's also at an accelerated increase in comparison to other age groups. Now, there are many reasons that could have contributed to this increase in neglect. As I say, we've touched briefly on financial pressures as a potential, but there are also other factors such as antenatal stress, antenatal bonding, poor nutrition, substance use, or perinatal mental health that can all have an impact on safeguarding concerns. And again, in terms of utilising the expertise in the audience and trying to have this as a two-way conversation now that I do have a voice, literally, it would be really interesting to hear any other perspectives or observations that people have made about what could be causing this latest increase in neglect. Now, I also want to touch on some specific factors that are being increasingly identified at the stage of assessment as well. And perhaps unsurprisingly for many people attending today, this is particularly the case when it comes to mental health. So mental health concerns of a parent have increased by 23% between 2018 and 2022. And it's now the second most identified factor at this stage of assessment. If the trend does continue though, then this year or the following year is most likely to be the most identified factor at that stage of assessment. Additionally, mental health concerns of a child have increased by over 52% in this same time frame, which is one of the fastest increases during that time period. We know that there are links between perinatal mental health problems and neglect, and with this clear illustration that mental health is a growing concern amongst both parents or carers and the child, investment in these services does need to match that. The large number of case reviews published since 2018, where children aged 2 and under were seriously harmed or died, reflects the fact that this age group is particularly vulnerable. Last month, NSPCC compiled a briefing analysing recurring themes across case reviews involving young children, the majority of which were under 1. I'm just going to briefly touch on some of the prominent themes coming through in this briefing, but I'll definitely be more than happy to share the briefing after this presentation as well. So we know that this age group is particularly vulnerable due to their age, and a part of this is their inability to communicate their needs verbally. The case reviews highlighted the importance for practitioners to be given the time, space, and expertise to understand an infant's lived experience, being equipped with the skills and resources to identify an infant's needs. The briefing also outlines that practitioners who regularly encounter high levels of need sometimes become desensitized to circumstances that would otherwise be classed as concerning. Desensitization can particularly influence neglect experienced by the early years, due to neglect often being identified through a combination of factors or incidents that collectively build a picture. Similarly, it shows that the workforce needs to be given the space and support to deal with complex cases, particularly considering how this may have a knock-on impact on the support available for other families and children. Across many cases, there is also a significant point on continuity of assessment or service interaction. A great deal of weight is placed on identifying new or developing risks, particularly when it comes to neglect. Similarly, knowledge of understanding observations, trends, or interactions from previous engagements is critical. Therefore, having the workforce provide this continuity of care to enable detection and identification of any trends, but also, as Georgina touched on, I was going to say will touch on later, but has touched on earlier, that element of actual building the relationship with the family and child is really important as well. And where that continuity isn't possible, it's essential that professionals have the space to be able to share observations and informations. So as I say, in neglect, when it's that build up of the jigsaw, pieces aren't being missed in that. Another recurring theme across case reviews allude to the involvement of fathers and wider family members. Case reviews have often identified this as an area that needs to be improved in order for professionals to build a more comprehensive picture of family circumstances. However, there are a variety of challenges in achieving this. The Child Safeguarding Practice Review Panel's reports, The Myth of Invisible Men, noted that the stark reduction in health visiting workforce, alongside a reduction in the public health grant, has led to local areas struggling to deliver core services at the same time as developing capacity to engage with fathers. So in order to support professionals to gain more understanding and have the time to actually implement that understanding, which could have an impact in reducing neglect in the early years, there is a need to actually resource the workforce so that they have the space, capacity and time to consider those themes. Now, this was going to be a bit of my transition side into Georgina's point, but I suppose that's been made slightly redundant. So I'll see this as maybe a little bit of an overview of some of those themes that are coming through. So as we've seen, neglect has been on the rise, particularly amongst the early years. There are a variety of factors that could be at play there, and it's really important that we have the preventative approach in tackling that. And as Georgina has so wonderfully demonstrated in the first half of this presentation, health visitors are a workforce who have the potential, if fully resourced, to play a key role in supporting families and children, identifying early signs of safeguarding concerns, providing preventative support for the family, and then also potentially signposting them to further support if needed as well. So that's just a short run through of some of the topics we've covered. And yeah, hopefully that has left a little bit of time with all the technical mishaps to take some questions. So I'll stop sharing there and bring Tamora back in.
Great, Jack, thank you so much. And thank you for recovering everything there. While you've been talking, we've had a series of questions in, so thank you all those in the audience who have sent something in to us. Before I delve into the first one, I would just want to check, Georgina, that you're also back in the room. Great, super. Super, because I thought I'd let Jack have a slight breather there and start you off, if I may, with some questions about the role of health visitors that we've had from the audience. So just to start with, a question from Chris, which is, what challenges do health visitors experience in engaging fathers specifically? And also, what training do health visitors receive to be able to engage fathers effectively? So I wondered if you could just talk a little bit about that, if that's a point that you're able to answer here.
Yeah, sure. So in terms of engaging fathers, I mean, it's crucially important that fathers are involved right from the beginning, right from the antenatal contact, all the way through for every single visit. So every health visitor would be think fathers and make sure that they're involved. But of course, you know, there are challenges around kind of the hours that health visitors work. And also when fathers are around as well. So it's very much around trying to ensure that it's a convenient time for both fathers and mothers and co-parents, to be present at all of those contacts, because it's a partnership together, and it's so important that health visitors can talk through that transition to parenthood and be able to answer kind of any questions, and also to be identifying, you know, any concerns, you know, early if fathers are feeling kind of worried. So there are some challenges around trying to engage fathers, certainly, and particularly because we have shortages within the workforce, as I've sort of discussed in the presentation. So that means we have less time. So if we had more health visitors, we'd have more time. So perhaps where there are some barriers there, we'd have more time to work through those barriers. But certainly when you've got an effective, well-resourced health visiting service, you can really kind of focus on that. I know there was a second part to that question as well, wasn't there?
It was whether you got sort of training or just specifically in that area, if you differentiate in that way, whether there was training as part of a health visitor training program to engage fathers effectively, and I guess also, I suppose, worth reflecting on the extent to which partners, including fathers, are seen now, particularly in view of those kind of shortages of time that you've just talked about.
Yes, so in terms of the training, I think it'd be variable across the country. Unfortunately, it'd be great if it was sort of all standard. So I think depending on where you live, it goes back to that postcode lottery of support. But certainly at the Institute of Health Visiting, we have a raft of kind of training and resources for health visitors. So we have lots of our health visitors that are members of the Institute, and they have access to a whole suite of resources. We've worked quite closely with Dads Matter, and we've co-produced lots of videos and lots of really super helpful resources about how to kind of engage fathers in the work that they do as well. So it may be useful for people just to have a little look on our website, and I can share a link certainly afterwards.
That would be great. And in fact, in and amongst the questions that I know you can see, we've had some sort of specific requests. For example, somebody would like to get a copy of the briefing that Jack mentioned. There's questions about some of the data sources that you've referenced. So please rest assured, if we don't cover all of those now, we will get a copy of these and we will reply to you individually to provide references, because Jack and Georgina between them have covered quite a lot of ground and presented quite a lot of information there. There's quite an interesting debate from a couple of people asking questions here, and in particular, I think in response to some of the points you made, Jack, about the research that colleagues at NSPCC have undertaken to try to understand the impact of the cost of living here. You also mentioned a concept that attendees are very interested in. Somebody has asked if you wanted to talk a little bit more about the concept of affluent neglect, because it's quite new, it's not discussed very often. We know that neglect doesn't only occur in households that have much lower economic resources. So this concept of affluent neglect that can take place in perhaps a context of a wealthy family, is quite novel. Is that something you could maybe talk through a little bit or describe, or is that something that you're looking into further?
Yeah, absolutely. And to be honest with you, the concept and the overall research about affluent neglect is a lot broader than what I managed to touch on in the presentation. So whether or not that's teeing up for another webinar, I don't want to sort of tee up a sequel too soon. But I can definitely share a little bit more information on that. So in terms of affluent neglect, I think, as I touched upon in the presentation, there's some different challenges in terms of affluent neglect, whether that be the form of neglect that's being identified. So that could be emotional neglect, which is sometimes harder to identify than other forms of neglect, where perhaps a baby or infant isn't receiving the right level of nutrition, or maybe the right clothing and things like that. So it can be harder to identify. It can be also masked a little bit in that it can happen even more so within the private sphere. That may be where families can sort of take themselves away from the spotlight of any social service interaction, for example. But then also there are themes that almost can directly lead to a child experiencing neglect as well. So as I say, if it is that emotional side of neglect, that could come from the fact that, you know, they don't actually have a lot of face time, for example, with their parent or carer. You know, it could be that they're being passed around from one carer to another. And similarly, that can have a lot of knock-on consequences to multi-agency working. So if the family is moving around, or if the touch points with the family are changing at a regular basis, then sort of the link and the information sharing can be lost and become quite fractured quite easily as well. So that's just sort of like a little bit of an overview, but as I say, there is a lot more to it. So either in a future webinar in this space, or I will pop my email in the chat if you wanted sort of a further discussion. I'd be more than happy to share more information on that specifically.
Thanks very much. Another question here, if I may, for Georgina. So we've had a question from Lydia, just asking if you have a view or position at the Institute of Health Visiting on the pros and cons of health visiting services being contracted out by local authorities, whether or not you think this practice sort of impacts on health visitors' knowledge or feeling about the community that that they serve. That's a question from Lydia.
Yeah, a really great question, and probably looking at the graph, you can probably see from 2015, which is when health visiting then moved into the commissioning of local authorities. We've sort of seen this decline, so I can see what, you know, the question why it's being asked. But I think certainly our position at the Institute of Health Visiting is that our focus is about ensuring we have the right investment for health visiting so we can support babies and children. So it doesn't really matter kind of where the funding comes from. We just urgently need that funding so babies and children can be supported and get everything that they need and they deserve, really.
Okay, thank you. And there's some reflections I think you can probably see coming in from the audience as well around, you know, you talked earlier, and in fact you highlighted some pretty striking figures about the difference between different areas, which is often called a postcode lottery. We saw some local authorities, did you say, right down to 4% in terms of their achievement of the 14-day check. And indeed there's some reflections from the audience who I know are pretty expert and include a number of professionals, including I'm sure many health visitors, that there are different commissioning arrangements that are influencing this kind of postcode lottery provision. So I'm sure in relation to health visitors, we have some good insights there. Georgina's signposted to the website of the Institute of Health Visitors. We'll be sharing all the details in the chat. There is another question here. In fact, there's some suggestions, there's some helpful suggestions as well worth sharing. So for instance, Emma's pointed out that she had training from the Fatherhood Institute. So there's some good sources and resources that we could share also there. Chris has also asked, I don't know, Jack, if this is a question that you'd like to refer back to individually. Again, it's quite technical, but it's talking about the socio-economic backgrounds of the increasing number of people who very sadly are being evicted from their houses. I suppose there is a question related to that around the impact of that on children, if that's something you're looking at.
Yeah, no, thank you for that. That is really interesting. It is definitely something that we want to understand more of, in terms of, we know that overall there is a relationship between poverty and abuse and neglect, and there is some very good research out there. But in terms of the individual drivers, it is something that we definitely do want to understand a little bit more of. I think in particular with, I think it's the housing point, yeah, that you reference. You know, unfortunately, within like the last year to 18 months, there have been more cases of either evictions or incredibly poor quality housing, which is having an impact on a family and then also a child as well. So yeah, no, I think it's definitely an area that we'd be open to understanding more of. I think in terms of understanding that poverty angle even more, the children need data doesn't break it down in terms of that socioeconomic level. So it's hard to see where precisely the increase in neglect is coming from. So that's why certainly the data that's been referenced and any others that we can sort of do ourselves is really important to help build that picture. So thank you for that.
Okay, I think I've got one final question that I'm going to ask Georgina to answer, please, and then I'm just going to wrap up because we're getting near to the end of our time. And there's a question just here about what a health visitor does if they identify a difficulty with the relationship with the parent and the baby early on. How much will they be providing support if they've identified this kind of issue, and at what point they might refer to another professional, and if so, you know, where do they refer on to? And any reflections on that, please, would be great.
Sorry, I had my mute on. So yeah, absolutely. So if health visitors identify, you know, a concern, it's very much working in partnership with the families to kind of talk that through. There's various kind of tools, different kind of assessment tools that are used in partnership to be able to establish kind of those kind of worries and concerns that they may have. And we do have specialist perinatal and infant mental health visitors as well, who health visitors can reach out to and refer to, and obviously refer on to other kind of specialist services as well. You know, each family is individual and experiencing different things, and it might not just be looking at you know, mental health in isolation. I think that's what health visitors are very good at, is kind of looking at kind of the wider picture and the holistic picture, and perhaps what may be impacting. And sometimes it's knowing when to kind of intervene as well, because it's the Maslow hierarchy of needs. Because if someone's just about to be made homeless and go out on the streets, you know, is it the right time to refer them to a specialist service, even though you can see that they're struggling? So, you know, there's lots of different factors, and this is why it kind of needs kind of those specialist skills of the public health training that they've got to be able to kind of identify those needs and know kind of what support to add at the right time in partnership with the family.
Thanks very much. That's great. Well, look, we're in our final couple of minutes here. So I just wanted to thank you ever so much, both of you, for your time. Thank you. Your presentations were excellent. I'm sure everyone found them very informative. A recording will be put up onto the Parent Infant Foundation's YouTube channel. So if you've got colleagues that you think would benefit from watching, then please do point them in that direction. And just a final reminder, please, if I may, just to all those on the line, the first 1001 Days movement is surveying all of our members, charities and individual professionals to ask what you think we should put into the manifesto that we're producing. And the point of that manifesto is to try to influence government, the UK government, ahead of the next general election, which is likely to be next year. So what we've heard today, I think, very sadly, is from both our speakers, is about the persistent trend of cuts and a persistent trend of deprioritising children and the early years, which leads to, very sadly, interventions happening too late. And what we want to do, of course, is get in early, provide support to these vulnerable babies and children as early as we can to improve outcomes. We want to address the workforce shortages. So please, by the close of play on Monday, that's when our survey closes. Hopefully you've got a link if you receive our monthly email newsletter, and a reminder also went out this week. And if you've got any questions at all, you can get in touch with us. There's a sign up link in the chat there, just to make sure you get our email newsletters. Please follow us on Twitter. You can see the YouTube link there, and we would very much welcome your ideas and your feedback to inform that manifesto, because we certainly don't want to be here in 5 years' time talking about a continuing trend of disinvestment. We want to take that scissors off the slide deck and hopefully see a bit of an upturn in what we know is incredibly effective use of public money, which is investing in children, preventing neglect and supporting those who sadly have been affected by it. So thank you all very much. Thanks again to Jack and to Georgina, and I hope you have a good afternoon.